I've taken an early departure because the room looked a little bit sparse when I went in earlier. But let's move on with our session now. So I'm just going to chair this session with two other sessions following our first one. And we're going to do a bit of a double act, Ali, aren't we? Yes, so that means, Ali, you come up here with me. And just to look at reframing physical activity as a core solution to improving health and well-being, and particularly in relation to looking at it from an active partnerships perspective. And we hope to go through our sessions and then get a local example from Rich as well. And then if there's time at the end of our session, then we'll do encourage you to add in for Q&A. No heckling's allowed, by the way, but Q&A is always welcome. So I'm Annie Holden, Strategic Health Lead in the Active Partnership National Organisation, and Ali Clements, who works with us on one day a week as well as within...
Actually, I'm sorry, yeah, I'm from Active Together, formerly Leicestershire and Rutland Sports, so the Active Partnership for Leicestershire and Rutland, and I have a role around the economy and growth, so it's business, skills, career pathways, tourism, and everything else that falls underneath it.
And then our colleague Rich Claydon from Active Oxfordshire will come in and do the final piece of our session. So let's just to give you an overview of the session today. So we're just going to talk to you a little bit about the Active Partnership Network. How many active partnerships are in the room actually? Have we got some? Good. Yeah, you can claim that one. But bearing in mind that not everyone knows who active partnerships are, so I'll just give a little bit of a background to that. In relation and consideration of the state of the health of the nation, which we've already heard obviously quite a bit about today, and how we're thinking about reframing physical activity as part of that health and care system, the role that our network can play within that, why our workforce should be the first mile of healthcare, and where are the national priorities and who's working in this space at the moment to actually make these things happen rather than just talk about them. So first of all then, just in relation to the active partnership, so we are a countrywide network, so the map represents every county, roughly coterminous with the ICSs across England. So there's 43 in total. We're a system partner of Sport England, and therefore Sport England is our core funder, but active partnerships have other sources of funding as well. And collectively we work to influence and shape national system and local place approaches to support moving more as the drivers for social change. And each active partnership is an independent organisation, mostly charitable organisations, and they act as the strategic enablers, the honest broker type approach to connect across the stakeholders within their area, and essentially then focuses on inactive people and those underrepresented groups to improve health. And in the national organisation, we're again an independent charity of the wider network, and our role is to connect, strengthen and enable. And in this space it's particularly looking at improving health through addressing those strategic priorities in order to reduce inactivity levels, particularly in areas of need. And just in relation to our network, we are increasingly recognised in relation to the core systemic role that we can play for creating the conditions at place for a healthier active nation. They're recognised as the place-based experts because they have that local insight and intel into their local communities. They develop those strong local leadership to build those trusted relationships with their ICSs in order to prioritise physical activity and enable it to be more of a core solution to improve health across the local health and care systems. And they also help to address the pressures of economic inactivity with support for a healthier workforce. And their central purpose in all of this is on tackling inequalities. And in a recent survey that we conducted across the entire network in relation to their position in health and in terms of what the priorities were, 95% of our network told us that health is either an essential or high priority. So it's critical in that space, and therefore very much aligns to what we're talking about today. But we also know that there's a very bureaucratic system out there. It's very complex, and it's very segmented, and it needs awful amount of navigation through it. We also know, and if any of you were in the session before lunch in this room with Tara, that our workforce is 58,000, 100,000 I think she quoted, that we are very much an untapped workforce and unrecognised. And we also need to consider that it should be perhaps more inclusive and representative of the communities that they're serving as well. And if we look at integrating pathways into health and care, which is that essential priority that I talked about earlier, we need to have something where it provides a bit more of a connected, structured framework, which will help provide a bit of a toolkit approach to the active partnerships and also the local providers, the local delivery people, and at which that then can be developed as a framework which can then be locally applied. And perceptions of risk, as I'm sure many of you know, are huge barriers, and the issues around medical clearance and medical guidance are also urgent issues which need to be addressed. And therefore, collectively, we're looking here at the workforce as well as the pathway, and the pathways need that strong national and local advocacy, and our workforce also needs to have that national recognition in terms of the value that it could bring in terms of reducing the pressures on across our health and care systems. Now, I'm not going to go through these in detail, because just to give a bit of background context to say, so why is it a busy space? Why is it a high priority for the active partnerships working with their local partners there? And there's various pieces of publications and evidence that came out. So the Hewitt Review earlier this year, it talked about increasing more local autonomy and more of a focus on prevention at a local level. The consensus statement, which came out a few years ago now, which fundamentally made it clear the evidence was really strong to say that the benefits fundamentally outweigh the risks for people with long-term conditions to be physically active. More recently, we've had the Major Conditions and Disease Strategy with the appointment of Professor John Deanfield, who is appointed as the government champion for personalised prevention, and looking particularly at how to radicalise the approach to cardiovascular disease prevention. And the more recent Get Active strategy and the National Physical Activity Workforce. I'm looking at one and then the other. I'm going to get over here really. But yeah, just to point out this one here, the National Physical Activity Workforce that has just met for on the first occasion, having that cross-government approach as well, and trying to bring inequalities and physical inactivity to the forefront there. And of course, so is one as well, Ali, in relation to...
Yeah. So you've probably seen quite a lot of those, hopefully you have, and there's quite a lot of talk about children and young people, but I think sometimes we miss the fact that there's a report down the bottom left hand, returning to the workplace, the motivations and barriers for people aged over 50, and that will probably come into some of the context of what we're talking about in a bit.
And again, I don't need to tell you this, but just to get the whole perspective on this, from a health policy perspective, as we can see over the last 15, 18 years, what's happened with that, and obviously the health and care, the integrated care systems were brought into place to provide more of a wraparound care approach to the individuals and the communities. And throughout the time on this, there's been this increasing emphasis on prevention, personalised care, self-care, a very untapped area of our NHS, and how we can then empower that self-management. And that's where our workforce is entirely fit for purpose in order to suit there and to reduce those pressures ultimately. And then again, stats, I'm not going to go through the detail with you, but you know, we know that it is important. We have to do something now. It's imperative that we tackle this now. If we look at the stats in relation to our ageing population in 10 years' time, that's going to increase to 22% of the population. We know that 2/3 of the adults by 2035 are more likely to have multiple long-term conditions and experience increased mental health problems as well. The number of years that we're expected to spend in good health will continue to decline, and of course there's huge variation across those areas of deprivation as well, and particularly across minoritised ethnic groups. And the how to do this, and obviously we work very closely with Sport England in relation to this as well, and the health team, and their 3 opportunities for change are highlighted on the slide here, and I'm going to come back to one of the latter ones a little bit later. But in relation to that, the critical point is if we overlay this, and yes, we're living longer, but we haven't got a great quality of life. And in addition, if you just look at that stat there from recent, you know, this is the working age population, 20 to 69-year-olds, which is projected to increase only by 4%. And yet that's the group that generates the bulk of the government spend, including NHS. And if you lay that as well in relation to the economic inactivity, which continued to rise, with increasing long-term sickness and retirement rates from the data that's collected 2019 to 2022, we have got to significantly do something different, because health of the economy moves in lockstep with health of the population.
Yeah, so it's not just the health issue on the budget situation. It's a real big challenge for the economy. Can you hear me all right? Yeah, great. You'll know from the news probably that the labour market's been squeezed for some time. Employers and businesses need people, and they need people with skills, but they need people to be well enough to come to work, and they need people that are able to stay in work as long as possible, and to be as productive as they can when they're at work. So above the line, what we've got is why we need to do something, and then below the line again is the how. So we know the data, and I'll show you some in a moment, that the long-term sickness levels have increased over the last few years, and people have been exiting the labour market. We know that the working age population is predicted to increase by only 4% by 2040. And as Annie's already mentioned that from the government revenue, but that also means that those people that will be going to work will all probably be caring and looking after other people in their lives, whether they're older, younger, or partners or family members, or they may well have health conditions of their own. So we've got to be really realistic about how much pressure you can put on just a small group of the population. And we need the people that are in work to be able to stay in work as much as possible. So below the line, we've got the three cogs there, and that's about how do we do it, what do we do? We need to enable and retain our existing workforce, and we also need to recruit people with lived experiences that our customers, patients, depends how you refer to them, can relate to, trust and work with to help them move more for their health, well-being and quality of life. We need to support businesses and business resilience, business survival, and we need to support micro businesses and self-employed people, because that's the majority of our sector. And we can't forget the active environments at the heart of that, because that's actually places where people move more and businesses can operate. Brilliant. So this is just some data. It's the clearest graph that I've found to explain it. And all you're looking for here, on the left-hand side of the graph, if you look for yellow and turquoise. So the turquoise indicates the amount of people that are on long-term sick in 2019, before the pandemic. And the yellow indicates the people that have retired. And so there's an economic inactivity level. So people that haven't been looking for work for 4 weeks and are unable to start work within 2 weeks. And all I'm trying to demonstrate with this graph is the difference between the left-hand side to the right-hand side. And the right-hand side is January to December 2022. And the growth in the yellow and turquoise is really clear. We've got two big groups of the population who are now not working. The turquoise group is because they're not well enough to be able to work. So there's a place for physical activity there. There's also a place that physical activity might help them move more and provide an opportunity to work in a way that they feel comfortable, whether that's a few hours a week or full-time, whether that's face-to-face and moving more with people or behind a desk. The sector's well placed to offer roles. There's also the group of people that are retired. That was the report I showed a moment ago, that barriers, I think, to returning to work and the barriers and motivations of people over the age of 50. It's a really interesting report if you haven't read it. It tells you exactly why people were leaving or coming back to the workforce, and how potentially our sector, in my view, can be very well placed to be a brilliant place for some people to return to the world of work in a way that they can manage work in their life as they choose to. So that's that data there. So I'll pick up the next one. So we know that physical activity remains chronically underutilised within and alongside the NHS healthcare and population health management. And so what if we did reframe physical activity as part of the solution to the health and care system? And there's a lot of data up there, so I won't go into all of it, but we know that reducing the estimated loss of earnings through long-term sickness, which costs the UK economy 43 billion in 2021, is equivalent to 2% of GDP. These are the figures that might ring bells with different departments who might be ready to hear it. And we know that we need an integrated approach, a healthcare system that prioritises physical activity as part of and alongside routine healthcare, recognising that physical inactivity is a key risk factor for poor health and systemic approach, and taking a systemic approach to identifying and supporting inactive people.
So what's happening about it? So first of all, then, from a national perspective, there is a physical activity and healthcare collaborative group, and it's represented by some of the logos are on the screen here. So you can see it's wide representation, and we meet bi-weekly. So we don't just sit and navel gaze and just talk about the problems, but we do actually have an action-focused agenda. And I have to say, it's probably the most action-focused I've seen since the years that I've been working in this space. And I think someone said earlier this morning, that there is huge ambition across our sectors now in order to work more collaboratively across physical activity and healthcare. And I think this group is one example of how that's happening, because that wouldn't have happened a few years back. But it is more around pushing the agenda and to address the fact that how to make physical activity a norm for the prevention and management, rather than doing these things more apologetically as has been done in the past. And coming back to Sport England, who obviously is a key part of that group as well, one of their opportunities for change, I highlighted 3 on the screen earlier, but one of those, just to bring out and reiterate, is improving the pathway between health and organised activity. So there was a consensus statement that was released, and clearly that was amazing information, because there was robust evidence there that had gone through that Delphi process to say that no better thing for someone who's got long-term conditions to be physically active. And then there are all sorts of unintended consequences that fell out of that as well, which are now starting to be addressed. And one of those, as the slide said, is by removing the barriers associated with risk, and it'll tackle that medical clearance versus medical guidance conundrum as well. And connected to that comes back to these pathways. So if we want to integrate physical activity into health and care, we need to look at the pathways into that space as well. And Sport England are now invested in that particular piece of work, and they want us as a national team to manage and coordinate that piece of work, to look into those physical activity pathways, and to utilise our network, because those are the guys that are expert at place, and then connecting with their local stakeholders and then other national stakeholders as well in this space. So just the last one in terms of exactly what we're doing here.
Yeah, so we've talked about reframing it and recognising the wider contribution to the health and care system. I won't read all those because you would know them. Hopefully we're all living and breathing them. But what we need to do is develop a framework and valid tools that ensure that physical activity is underpinning the infrastructure, and it's fit for purpose and it's fully supported, because the scale of the need, we're all quite aware of the scale of the need. So there's 3 aspects to this. One is for the operational elements of the physical activity and health pathways to provide frictionless pathways into health and consistent quality assurance models. We also know that we need to develop a representative workforce that is customer-centric, inclusive, and equipped with the right skills and behaviours to provide the specialist support required by trusted health professionals. And we also know that there's still a big job to do to advocate for the work in partnership to scale up the quality and quantity of the accessible physical activity opportunities to support people with specialist health needs. Therefore, it's a vast health and social potential, opportunity and challenge, but we need to do it because they're the people that need it most.
So we just want to finish this slot with showing a very short video from Kevin Fenton. He's actually pulled this video together for a Live Longer Better active partnership meeting that we're hosting next week, and he couldn't be there, so he's done this video, but it speaks to what we're talking about now. And just to put the context, we work with Samir Gray on the Live Longer Better movement, and Muir is excellent, knocking on doors and saying, can you do something for us? And then Kevin produced this, but it's very, very appropriate in relation to what we've just been talking about. So it's just a couple of minutes, if it works.
Hello, colleagues, and thank you to Sir Muir for inviting me to say a few words today. I'm Professor Kevin Fenton, the President of the Faculty of Public Health. Now, unfortunately, I'm not able to attend today's events in person, but I want to record a short message of support for the excellent work you deliver to support people to live healthier, longer, more enjoyable, and more productive lives. With the number of older people in the United Kingdom increasing, it is so important that we reframe our approach to preventing ill health in old age and to follow the evidence and do all that we can to support people to live longer and better lives. If the health and care system overlooks the opportunity to engage with physical activity specialists and embed physical activity into routine primary and secondary care settings, particularly in older age, then we miss a key opportunity to make crucial public health interventions to protect and promote health. This roundtable event, bringing together national Live Longer Better partners, is an opportunity to both reflect on progress made by the LLB movement and set the direction of travel for the coming years. As a skilled workforce of qualified exercise specialists and activity instructors, coaches, and volunteers, you are delivering a key public health role in improving health and encouraging active aging within your communities, particularly for those with long-term health conditions and other vulnerable or marginalized populations. This work is so valuable, and it is imperative that we recognize and advocate for the role of physical activity and the professionals who support these programs in our wider health and care system. If we can support healthy aging, we can not only reduce pressures on our NHS and social care systems, but we can also support more people to remain healthy, happy, and productive into older age. Now, we cannot deliver on this agenda without the expert work of physical activity professionals across the health and care system and the wider community. And the LLB movement is so important in drawing together the leadership, the knowledge of physical activity professionals to advocate for change at national level. The Faculty of Public Health fully recognizes your contribution as part of the skilled public health family, and we look forward to working together to support better health for all.
So I think obviously that just speaks to and a huge advocate for the recognition of our workforce, which and our workforce has not had that national recognition. And I know I've worked in clinical multidisciplinary teams in the past, but as an exercise person, there is no professional registration in the same through an allied health professional perspective, other than of course we need to tap into CINSPA and the support that they can give us as well. So by working with these key figures and national stakeholders, including CINSPA, UK Active, etc., that's how we intend to drive this on. But I think it's really important now just to give some local context of how that's actually working in place. So I'll just hand over to Rich.
Oh, that light's bright. Thanks, Annie. My name is Richard Claydon. I'm the Head of Strategic Health Partnerships at Active Oxfordshire. Every time I say that, it seems really long, so apologies for the long job title. You understand the role of Active Partnerships, if you didn't already, and mine is specifically looking at working with those adults with long-term health conditions, older adults, those suffering or struggling with their mental health, to create those pathways to activity, but also to tackle those inequalities. And that's our role overall.
Hello.
Oh, hello. Perfect. So, Move Together is our pathway in Oxfordshire, and this is my task is to bring this to life, and what a lot of Annie and Ali have said. And we've been on a bit of a journey over the last 2 or 3 years to create a pathway, ultimately, to support people around behaviour change and finding the right activity that can support them to manage their long-term health conditions. But also, ultimately, to try and reduce pressure on health and social care, and just to build those relationships, to really understand physical activity, how it can work, but ultimately trying to get it over a long-term vision. So I'm not sure, lots of people in the room might be doing year-on-year contracts and trying to ultimately commit to physical activity over a longer period of time to see those benefits, see the impact that we're having. Move Together has been a fundamental part to that. So previous to Move Together as a physical activity pathway, we linked to leisure centres and exercise referral schemes that I'm sure a lot of you are aware of. And we had a single pathway for diabetes, so type 2 diabetes. And the opportunity came around to try and create something using COVID-19 recovery funds to support people to move more and improve their physical and mental well-being. And that has led us on a journey, really, to work with the health system to say, actually, this is really, really needed. Both from the pressure perspective for health and social care, but because the management of long-term health conditions and those who are inactive are the people that stand to benefit the most ultimately. So that's got this system-wide vision, and as part of that, the reason Move Together is so important is because the evaluation that we've put in place has allowed us to make a case for physical activity within the health and social care system, and to show the benefit across a variety of systems and create a vision that actually physical activity is important not just for health, for social care, hospital discharge, a variety of services, and to make that case that actually it's needed. And without that evaluation, we'd really struggle to do that. So I've listed some of our partners at the bottom there, and these have been the people that have been getting around the table and saying, how can we build on Move Together? How can we make this case for physical activity? And importantly, can we invest in it for the long term to make it work for everybody? To bring it to life, I need to talk about Move Together itself. So Move Together is a pathway that is in partnership with district councils. So we essentially coordinate the pathway, and in our 5 districts, the local authorities have a Move Together team. And they essentially receive referrals, health referrals, self-referrals into their local authorities, where they'll have a conversation with somebody to find out ultimately what is the best way of them moving. So we're moving away from, not moving away, there's exercise, there's fitness, there's activity, we're using the words movement, we're trying to reframe it a little bit to ultimately find the right thing for someone to get active with. So it's not just going to be about going to gyms and doing exercise referral and swimming, it's also about, if someone is feeling isolated and lonely and they're in their home, can we provide them with a resource to build their confidence, to reduce their risk of falling so they can eventually re-engage in the community. So we're really opening up a little bit to the traditional couch to 5K, join the gyms. It's about home activity resources. It's about things in your community that work for that person. And to do that, this pathway has to be person-centred and it has to be around behaviour change. It's about those conversations with people to find out what are their barriers and what do they like doing, importantly. And I think what we found a lot is that actually the feedback from participants has been, in the qualitative quotes, has been around about encouragement, support, motivation, which shows that that behaviour change element to it is really, really working. And people want to know that there's somebody there who's going to call them, who knows their name, and is building up a bit of a relationship with somebody to then support them over a long period of time. So you've got your referrals, they have initial conversation, and then we signpost them to activities that we think are suitable. So we take a county-wide approach, and in each district there's a very much a place-based approach to find out what's available in their area. We're often asked or told by health professionals that they don't know what's going on out there. Programme names change, I'm not sure what activities are out there. We have got a database in each area that tells us exactly what is on in the area, and that is built by those Move Together teams in each district. So we've got a filtering system where it might be that we're putting low cost and walking, and it will bring up a list of all the walking activities, and then we would signpost them to that. And we also use journaling and those behaviour change tactics to support people over a 3-month period. So in that 3-month period, they'll probably have 3 or 4 touch points with a Move Together coordinator, who would find out how they're getting on, try and motivate them, encourage them. If the activity's not working, they'll try something different, all with the goal of trying to give them the tools to self-manage and to keep active moving forward. Sometimes that doesn't happen. We've got a 96-year-old lady on the pathway, and she's been on it for a long time now, because she's always going to need that support. So coordinators go out and they link hands with her, and they go for a walk, and she says that's the only time she ever sees anybody during the week, and she's being active, so it's really positive. So there's some people in ongoing support, but we've kept it out 3 months as our guide to try and support people as much as we possibly can over that. So hopefully that just gives a bit of detail on the pathway. But importantly, to reach across systems and to engage public health, for example, and wider services, we're not just signposting to physical activity. If those conversations coming up that there's other barriers that we need to be aware of, mental health, for example, we will then be signposting to other services in Oxford to support the participants. So it might be that we signpost somebody to a walk, but at the same time we refer them on to Oxfordshire Mind to receive that support to actually get them to go to these activities. Could be around nutrition. So it's that wider system, and obviously priorities for public health, for example, might be smoking cessation. So obviously we can support those areas by linking all these services up and providing a wider system pathway. Okay, so outcomes. So far we've got greater connections to health and physical activity. So that's been a key thing for us. Having this pathway where people know where they're going to, it's quite simple, it's accessible, it's one centralised resource to go into, which will then find the right person, has really helped to build those connections with primary care especially, because I think that's something they say is a challenge a lot, is we don't know what's out there, we don't know if it's still running anymore, and if we can provide that physical activity support for them, they will send referrals into us, and then we then support from there. But also with those connections with the Integrated Care Board and this ongoing funding, which I'll come on to a bit later, we can start tapping into priorities in different areas of the health system to make sure that our pathway is doing our best to support that as much as possible. I had a conversation last week around how we can support the hospital discharge to stop people being readmitted back into hospital by keeping them moving. That's a conversation that definitely wouldn't have happened 2 years ago, because they can see the support that's happening, and they've got a resource that can support the health system to try and divert slightly and support a different agenda. Another example that came to me recently was the place director asking us how we can support NHS workforces around their physical and mental well-being. So we can start being targeted. Secure long-term funding. So collaborative funding is the ultimate. So I said about year-on-year funding. We want to get to having long-term vision, long-term funding. We're close to securing a 3/4-year funding agreement with a collaborative commissioning approach between public health, the district councils and the integrated care board, which secures us to be able to keep learning, keep growing and doing more of the pathway stuff. And then I mentioned earlier the evaluation was a key part of it because we had a business case that we then used to sell this model and to get that long-term funding going forward. So I mentioned at the top the collaborative commissioning, and that's something that we're very close to signing off on. And Annie and Ali have mentioned about the pathways work, which is fundamental to what we're doing. We're learning over the last couple of years to understand what we need that pathway to look like. We're seeing it all the time in terms of that consistent framework across the county, having the barriers to risk that Annie mentioned, that's come out all the time for us. So being part of that consultation for us would be really helpful to shape the pathway moving forward. We're noticing workforce, whether that be volunteers or those specialist level 3, level 4 instructors. There's a gap in there for us, so we need to be working on that and trying to upskill more people to support the pathway and the delivery. And I mentioned about some of the opportunities to use volunteers and support the hospital discharge system. There's still gaps in some primary care networks that we need to work with just to really grow the pathway and how it can support. And finally, just a few quotes. So just the top two are from participants who meet together. And then the bottom one is our Executive Director for Oxford's Integrated Care Board, who I think when we talk about relationships, these things are fundamental to have a good relationship with the health system, and he's been fundamental in pushing forward for a physical activity pathway. Without that, I don't think a lot of these conversations would happen, so it's really important to make the case for evaluation, but also have those relationships to build on it.